Good afternoon, everyone. Thank you so much for having us talk to you about thoracic oncology and nursing perspective. Of course, we would have all loved to be in Denver talking to you live, but given these times, we try to put up a background that that kind of tells a winter story, maybe a winter landscape in Denver. That's the best we could do. But anyway, glad to be here. I would love to introduce my colleagues. Timra Walsh is our super nurse. She's been our practice nurse. She specializes in thoracic and head and neck oncology. Keara is our PA. She is an adjunct professor at Hofstra University. She leads the PA program here with a lot of students, mentoring a lot of them. I am Nagashree Seetharamu, a thoracic and a head and neck oncologist. So I just want to start with non-small cell lung cancer, a little bit of a historical review. This used to be lung cancer diagnosis in the past. Non-small cell, small cell. If you got a diagnosis of one or the other, we were quite happy. And the treatments were very simple. This seems like, centuries ago, but this was in 2002. This was a landmark article by John Schiller, and this compared 4 platinum regimens. And we were very excited to note that the lines, overlapped each other. That was the level of our excitement back then. And then came bevacizumab. We got very excited because the overall survival extend beyond a year. I'm sorry for the typo there. But now we know that lung cancer is not just one disease. Non-small cell lung cancer is not just one disease. It's not even disease based on histological subtypes, but we are now down to the driver mutations. And this pie chart, no presentation in lung cancer is ever complete without having this picture, but this picture is constantly changing with new driver mutations being discovered almost on a monthly basis, with new agents being approved at a rapid speed. This is a pictorial that I borrowed from the Lung Cancer Research Foundation. You can see no activity at all from 1940 to 1990, very little activity. And then in 2000s, a bunch of chemotherapy drugs. And now in 2020, we are talking mostly about oral medications, some immunotherapies, maybe one chemo. So it's really changed a lot. So you can imagine how much there is for us to learn and how much there is for us to offer to patients. This is again another representation of all the FDA approvals for lung cancer from 2018 through 2021. It's still, we're just about March. This was accessed beginning of March, so already many approvals this year, and last year was really a remarkable year. So, the current landscape. We need to establish diagnosis, and everything has to happen at rapid speed because we think with targeted treatment, patients live longer, they live with good quality of life, and many patients, even with stage 4 disease, we may be even able to use the word cure. So histological typing is important, we get that immediately, and then we need to send for molecular testing. Sometimes, we may need to test primary tumors as well as metastatic lesions. If there are multiple tumors, we may need to sequence them separately. And then there's always the complexity of which tissue to biopsy. Bone biopsies we know are not as optimal because of decalcification and degradation. But then maybe PET scan might be helpful in determining which would be a better spot to biopsy. So all this happens in real time. We present many of these cases at our tumor boards, but a lot of time, we meet or we virtually connect with each other even in between the tumor boards. And then we have blood-based DNA testing, also called liquid biopsies, which also we do almost on a regular basis. And then we went over multiple mutations. There are so many targets and targeted treatments. And then we always push for broader molecular testing, and that's really extremely important now that we have so many targets that are not recognized by limited panel. And then even with squamous cell, testing is important. I think at this point, we might run into some issues with insurance, and but we always seem to get our way around. And again, I would like to thank my team here for making it happen for all our patients. And a PDL1 is another big thing. Immunotherapy is a completely different topic. I don't want to get into the nitty-gritty. Most of you know that the realm of lung cancer treatment is changing at a rapid speed. This liquid biopsy, basically collecting cell-free DNA from multiple sources, particularly the blood, and it's minimally invasive, and you can do it at multiple time points, and our nurse is of a vital player in getting these tests done for our patients. We do get results, and we are able to act on it even before the tissue sequencing is available. So I am going to stop here, and I'm going to give the microphone, I'm going to pass on the baton to Keara Barnaby.
Hi, and welcome, and thank you for being here and joining us for this program. As Dr. Seetharamu had alluded to, there's been so many changes in medicine, and specifically in lung cancer, that gives our patients a much better quality of life and a longer life to lead. So without further ado, I will present to you one of our patients. So the initial presentation of this patient of ours, he is a 75-year-old gentleman with a history of AFib, hypertension, gout, and BPH. He presented to his primary care doctor with multiple weeks of productive cough and dyspnea. He did not have any fevers and did not complain of any weight loss or chest pain. He is a never smoker. He was not an alcohol or drug user. He used to work as a chemical engineer in the Philippines, and as such reported some exposure to asbestos from his job. On initial presentation to his doctor, he was ordered to have a CT of the chest, which revealed mediastinal lymphadenopathy with a prominence of the right hilum and mildly enlarged hilar lymph nodes, some of which were calcified. There were also multiple pulmonary nodules, but were small, all measuring around 6 millimeters in diameter. The patient underwent a bronchoscopy and an EPUS, and he had a bronchial lavage, and mediastinal lymph node biopsy was positive for adenocarcinoma. He was then referred to our team, where we referred him for a PET scan, an MRI of the brain, and as Dr. Seetharamu had described, a mutational analysis of his tissue obtained on biopsy. PET CT and MRI of the brain, as you all know and are aware, is the formal staging for lung cancer patients. So the PET CT revealed a hypermetabolic mediastinal and right hilar lymphadenopathy with cervical and supraclavicular nodes, as well as a left axillary and retropectoral lymph nodes. Again, the scattered pulmonary nodules. MRI brain also revealed, unfortunately, an abnormal enhancing lesion adjacent to the right cavernous sinus, though it was suspected to be a meningioma and not a malignant process. The biopsy was sent for mutational analysis and was significant for nothing targetable, unfortunately. He had no EGFR, ALK, or ROS mutations, and PDL1 was also reported as negative. He was started on first-line chemotherapy with carboplatin and pemetrexed and completed six cycles with a nice response. He was transitioned from that point to single-agent pemetrexed maintenance, but subsequently developed pancytopenia, which necessitated us DCing the chemotherapy. With that said, we We then switched to second line treatment with nivolumab with stable disease for over 1.5 years. Subsequent to that, he developed late onset autoimmune mediated hepatitis, which required hospitalization. He also had acute kidney injury, pancreatitis, rash, and new onset diabetes. This was all secondary to the nivolumab and was subsequently DC'd. He was treated successfully with steroid and remained off therapy for a pretty significant amount of time and was monitored with 3-month interval imaging. Eventually, the interval scans showed progression of disease with a new left lower lobe nodule with worsening lymphadenopathy and a new osseous metastases, which you can see as indicated to the left. We biopsied the right supraclavicular node, and that was consistent with metastatic adenocarcinoma. And we also sent a liquid biopsy. This was returned to us quicker than the tissue biopsy and was positive for a CCDC6 RET fusion mutation. The patient was ecstatic, started on third line selpercatinib and was tolerating treatment very, very well. You can see that on the before treatment to the left of the screen, you can see noted a nodule, and the treatment arm, after 3 months of treatment, the subsequent imaging revealed resolution of that lower lobe nodule. He currently remains on selpercatinib and is doing terrific. With that said, I will turn the floor over to our amazing nurse who organizes all of us and all of our patients.
Good afternoon, welcome. Thank you for joining us. I'm going to go through some of the nursing perspectives. So starting with the initial consultation, prior to that visit, we have a team that gathers all the workup and the outside medical records so that we have all the records for the provider to review at the appointment. Unfortunately, sometimes they don't have everything, as was mentioned earlier. We have to get an MRI, a PET scan, and those things I will help to schedule at that time. The patient and the family, well, unfortunately with COVID, a lot of times it's just the patient right now, but I meet with them, I orient them to our process here at the Cancer Center, the treatment room, the different procedures on how to schedule, where the treatment room is, where the lab is. I provide education to them about their diagnosis and especially about the treatment. If at that point we know what treatment they're going to be getting. I will give them information sheets on the chemotherapy or the immunotherapy treatments. I'll go over the different side effects, the scheduling, how often they'll be coming, how often they'll be seeing the doctor. Back when this patient was diagnosed in 2017, at that time we only had a limited panel, a molecular panel, which would be done on the tumor cells, the tumor tissue itself. So if that needed to be sent, I would assist in organizing with pathology to get the specimen sent for the appropriate testing. Also, at the initial consultation, we'll sometimes find that the patient already needs to be seen by nutrition or have a social work consultation due to complicated social issues or transportation issues. So at that time, we can always get them looped into seeing the patient with us at that time. If not, all patients are eventually seen by nutrition and social work on their first treatment appointment. Also, as far as referrals, if they need to be seen in radiation or any of those things, I do help organize it at that time. So when the patient initially starts their treatment regimen, I will see them during their first treatment in the treatment room. I'll again go over the different side effects for the different medications they'll be getting. I answer all their questions. I'll go over their schedule. If needed, I'll provide them with a calendar so everything is right in front of them in writing so they can understand exactly where they need to be and when they need to be there. I ensure that they have follow-up appointments to see the doctor or Keara, the PA. We try to alternate between visits so that they get to see them both fairly frequently. I review the treatment profiles that get entered into the ordering system so that the treatment nurses are aware of what the plan is for the treatment, the dosing, and the frequency as well. And with that, then I have to verify the accuracy of the chemotherapy orders. I make sure that all the doses are correct, the frequency, that the patient is on time for their treatment, any lab work, that everything is within normal limits, and that the pre-medications are all appropriate for what they're getting. Especially with the pemetrexed, if they're due for their B12 shot, they should be taking their folic acid at home. But I keep a treatment log, so we know exactly what cycle the patient's on, if the treatment is held for any reason, why we held it, so that we're able to go back and look at that and know exactly what happened in the course of treatment for the patient. Again, I follow up with them in between treatments to ensure their compliance with taking their antiemetics if needed. If they're having any bowel regime issues, we address that. Any nutrition recommendations. The patient is very aware that they can call us at any time with any kind of questions, concerns, and that one of us will definitely get back to them. We always remain available to address any issues and triage their concerns. The treatment room nurses do know they can always call me to come over and see the patient while they're here in case there are any issues. In the change to immunotherapy, this is a time again where education is key because the immune-mediated adverse effects and toxicities are very different than chemotherapy, and that it's very important for them to timely report to us any issues that they are having. It's also sometimes different in treatment schedules. The timing might be different, how often they have to be here. So that is another time where I will do a lot of education with the patient. Biggest thing is keeping the patient informed and educating them as much as possible and knowing that they can reach out to us with any questions or problems. When disease progression occurs, this is a big time for supportive care. The patients usually need a lot of support during this time. They're very upset that the treatment hasn't been working right. So a lot of supportive care and emotional support are given to the patient at that time. This is a time now that we are able to do liquid biopsies where I will arrange for the collection, I process it, and I will follow up on the results. That's done in our lab. They're able to draw the tubes of blood, and then I will send it out to be tested. When starting on an oral medication, we are lucky enough to have a clinical pharmacist who assists us with following the patients on the oral medications. So I ensure that he is made aware of our patients, which will be starting on oral medications, and he re-goes over all the proper handling, the dosing schedule, any adverse effects that they can expect, and he's always available for education with the patient as well as our team is. I assist in scheduling labs because now that they're on the oral medication, they won't be in the treatment room routinely having labs. So I can arrange for home draws or for them to come into the office. Periodically, they'll need EKGs. So we make sure that those are getting done in a timely fashion and that they have the follow-ups with either the physician or the PA. So the additional challenges that we've had in 2020 and 2021, a lot of education that we've had to do with COVID-19. There's been a lot of education and teaching that we've had to do with the risks and the precautions that the patients have to take. Unfortunately, if they do become positive, there's a lot of education and arranging for them to have referrals to our team that follows the patients that have COVID-19 that are at home. We've been having to adapt to telemedicine, which has been quite a challenge. And teleconferences, which have been a challenge. It's been very different for the patients, and some of them just not having smartphones, being not able to connect. So that's been quite a challenge. Also now that they're not allowed to have family members with them. and the impact that it's had on our patients. It's very, very difficult time for them, and not to be able to have a family member with them or a friend accompany them has been very difficult. So we have made a point of visiting our patients more frequently than we normally would in the treatment room, just because we know how difficult it is for them to be there by themselves. And now with the COVID vaccine, we're getting several calls each day in regards to whether or not they're eligible for it, should they get it, what they should expect with getting it. So that has been a very big part of what I've been doing and our team has been doing, is educating the patients in regards to that. So that's really it. We're rapidly having things change with lung cancer, and we're looking forward to hopefully eventually having a cure for it. So it's very important for us to just stay up to date with everything. And we thank you for participating in our conference today.